Hi, my name is Edelyn Samways, and I will be doing a head-to-toe assessment on my patient. Okay, my name is Edelyn, and I will be your nurse today. I will be taking care of you. Could you please state your full name?
Xavier Ilias,
And do you know where you're at?
at the hospital.
Good. And do you know today's date?
April 23rd, 2020.
Very nice. And what is the reason for your visit today?
I have a regular
An annual checkup?
annual checkup.
Okay,
yes.
good. So you're here for your wellness exam. Do you have any complaints? How is
No.
your overall health?
No, it's just a regular checkup.
So everything is okay?
Yes.
Okay, so what I'm going to do now is just do a general inspection on my patient. And I see that on his arms and hands, I don't see any rashes, no lesions. I'm gonna palpate, and I feel that his temperature is warm. His skin is dry and intact and smooth. I'm gonna take his pulse now on both radial pulses here, and I feel that they're equal and strong, a +2. I'm gonna check for capillary refill. So I'm gonna squeeze his nail bed, okay, on both arms. Can I have your hand? I'm gonna squeeze, okay, and capillary refill, anything less than 2 and 3 seconds is normal. It shouldn't last longer than that. I'm going to pinch the skin on his hand because I'm testing his skin turgor for tinting. This is to assess if there are any signs of dehydration, and everything looks good. And I don't see any signs of edema. Now a little range of motion. Well, before we do range of motion, I want to look at his nail bed, the profile. And the profile should be about 160 degrees. So that shows no signs of clubbing. Clubbing would be an indication of possible hypoxia. So anything greater than 160 could lead to clubbing. Okay, and now range of motion. So if you can make a fist for me, please. And you're gonna flex, okay? Extend and flex. And then you're gonna spread your fingers out, abduction, and put them together. So that's abduction, good range of motion, very nice. And I want you to squeeze my hands. Can you squeeze both? Okay, good muscle strength, so 5 out of 5, excellent. So I'm gonna continue now with head and neck assessment. I'm going to check C-spine. Okay, so we're gonna do a little more range of motion. And I want you to just look straight, okay, and then flex forward, hyperextend back, and then rotate to the side, both sides, good. And then lateral. All right, very nice. And shrug your shoulders for me, shrug. Okay, good strength and range of motion. Okay, I'm going to start by his pupils. I want to check that they are reactive to light and accommodating. So I'm going to get my pen light. Okay, we're going to check for Perla that his pupils are equal and round. They react to light. I see consensual constriction, direct constriction. And if I can have you please focus on something behind me. Okay, if you can focus on that behind me. And then just follow my pen light. Look at my pen light now and follow. And I see accommodation. So his pupils are reactive to light and they accommodate. So these are all normal findings. As I look into his eyes, I see that the sclera is white, that his conjunctiva is clear. So these are normal. And I'm going to assess now my patient's nose inside his nostrils. So if you can look up for me, I'm going to grab my pen light and I'm going to look inside. And I see that there's no obstruction to the airway. His nares are clear. The septum is midline. I don't see any trauma. And it's nice and moist. Everything looks okay. And I'm going to now assess the inside of my patient's mouth. Can you open and say, ah?
Ah.
Okay. Now, very nice. Good, good. It looks good. You can close. As my patient says, ah, I see that the soft palate rises. His uvula is midline. I see that the mucous membranes are pink and moist. There are no blisters or lesions, no signs of fungal infection. His tongue looks healthy, and I see that there are no cracks on his lips, they look moist and pink and congruent to ethnicity. Okay, I'm going to check his trachea, make sure that there's no deviation to the right or left, that it's midline. I'm going to check carotid pulses, one at a time, of course. And I will check, okay, and I feel a strong pulse on both sides equally, so a +2. If I wanted to auscultate for any bruits, I could do that in the 3 points of the carotid. And bruits are is turbulent blood flow. This would be an abnormal finding. Okay, so I will now move on to respiratory. So the first thing I want to assess is AP transverse diameter should be a 1:2 ratio. So can I have you stand up, please? Thank you. And so I see that the AP 1, transverse 2, so normal. And then, if you can just stand up, I see that my patient does not have any trouble breathing. He's not showing signs of dyspnea. He's not using any accessory muscles to breathe. So this is very good. I'm going to now check that my hands rise equally bilaterally as he takes a breath in and exhales. So I'm going to palpate for the 10th rib. Okay, and I need you to inhale and exhale. Good. And I saw both my hands rise equally bilaterally. This is very good. I'm going to now assess tactile fremitus. And as I do this, what I want to feel on the palmar side, on the ulnar side of my hand, I want to feel equal vibrations on both sides as I palpate. So I want you to say 99 each time I move down with my hand. Can you please do that?
Yes.
Okay.
99, 99, 99, 99.
Excellent. And I felt that vibration equally on both sides. Okay, very good. Okay. Now, just a quick explanation before I go on to auscultate lung sounds. There are 3 types of sounds that I'm expecting to hear. I have bronchial sounds, that's over the trachea. And this is a high-pitched sound. The inspiration is slightly shorter than the expiration, about a 1:2 ratio. Then I have bronchiovesicular. This is over the bronchi. This is a 1:1 ratio, so expiration and inspiration are about equal in duration. And then over the lung fields, I have vesicular sound. This is a low-pitched sound, and the inspiration is slightly longer than the expiration. So these are things I want to keep in mind. Also, I want to keep in mind that I should have resonance in the lung field. This is what I want to hear for. So I'm going to assess for lung sounds. I'm going to first, if you can first do bronchial, okay? Take a deep breath in, exhale, deep breath in, exhale. We're going to do bronchiovesicular, okay? And just to speed through the process, I would do this in all the areas. I would also, can you please stand? Thank you. And I'm going to check vesicular sounds over the lung fields. Can you take a deep breath in, exhale, good. And I would just continue making sure I hit all the spots. Okay, I don't want to miss. And I would assess all the lung sounds. You can have a seat now, just so I can explain. If I were to hear any abnormal sounds, any wheezing, any crackles, anything that sounded abnormal, I could do other tests to further assess if there's any consolidation. So I can use bronchophony, have the patient say 99 each time I move my stethoscope. And if I heard a muffled 99, this is a normal finding. It's what I expect to hear. If the 99 were clear, this would be abnormal. It could indicate consolidation. Egophony is similar, except that I would ask the patient to say E each time I move my stethoscope. If I hear E, this is normal, this is good and expected. If I hear A at any point, this would indicate an abnormal lung sound. It could mean consolidation as well. And finally, another exam I could do is whispered pectoriliquy. I would have my patient whisper 1, 2, 3 each time I move my stethoscope. If I heard a muffled 1, 2, 3, this would be a normal finding. If I hear clear 1, 2, 3, then this might be indicative of consolidation and need for further assessment and evaluation. Okay, that's for lungs, and now I'm going to move on to cardiac. So I'm going to have my patient lie down. You can lie down here. You can put your head on the pillow, just make yourself comfortable. Now, I would raise the height here, the head of my patient about 30 degrees. So we'll just imagine that this is elevated about 30. I'm to the right of my patient, and first, obviously, I would have chest exposed in a regular situation at a hospital setting. In this, I'm just going to inspect first for any heaves or lifts. And then I'm going to perform the jugular vein distension using the 2-ruler test. So I'm going to have my patient turn his head to the left, okay? And I'm going to first locate the angle of Louis. The angle of Louis is that junction between the manubrium and sternum. It's that. So this is the angle of Louis. I'm going to get my centimeter ruler. I only have one, unfortunately, but I'll just imagine with my hand, and I would put it at that point. I will find the maximum impulse of the JVD, and I will measure. Anything that is less than 3, 4 centimeters, anything less than that would be a normal finding. I don't want to find anything higher than that because it could indicate a more serious problem. If I wanted to elicit the distension of the jugular vein, I would perform the hepatojugular reflex. I would place my hand on the right side under his rib cage and press down. I'm going to press down here, okay? And his vein, so I'll press down, and the vein should distend. As soon as I let go, that vein should collapse and empty. This is what I want to see. If it stays distended and full, again, that would be an abnormal finding. Okay, I'm going to auscultate the cardiac sound, and I want to locate where I'm going to do that. So I want to find aortic, pulmonic, tricuspid, and mitral. And I want to listen to all those areas. I'm going to first listen with the diaphragm. Later, I can do it a second time with the bell to hear for any murmurs or extra heart sounds. So I'm going to put this on. Okay, we're going to first start with the aortic. Okay, so the aortic is going to be on the right sternal border, about the second intercostal space. Okay, and then the pulmonic will be left sternal border, second intercostal space. The tricuspid is left sternal border, third or fourth intercostal space. Oh gosh, okay, right. And the mitral is left mid-clavicular, and I would listen to all those areas. The second time, use the bell. When I use the bell, it's more appropriate for hearing murmurs, or for any extra heart sound. So an extra heart sound would be S3 or S4, and I'm going to discuss S3. S3 would follow S2. It's known as the ventricular gallop, and this is a pathological issue if you have excessive fluid, and this is indicative of heart failure. It's best heard in the left lateral side at the apex, and it's physiological in children, young adults, athletes, or pregnant women in their 3rd trimester. It would be a physiological finding. All right, and now I'm going to move on to the abdominal inspection. So I would remove the shirt, but here to keep modesty, I'm going to keep this here. But the first thing I want to do is just inspect. I want to see if there are any visible abnormalities, any hernias that are visible to the naked eye. rashes or any lesions. I want to see that the abdomen is flat or round, depending on, if they're chubby or not, but it should be rounded or flat. It should not be scaphoid. It's like that sunken in belly. That's a problem. That's not normal. And it shouldn't be protuberant. It shouldn't be a pot belly. So that's not a normal finding in an adult, a protuberant belly. Protuberance is normal in a toddler. So for example, my daughter is just over 2 years old and she's got a protuberant belly. This is very normal in young children, okay, but not in adults. So after I inspect, I don't want to palpate. I want to auscultate first because I don't want to elicit any false vowel sounds. So I'm going to auscultate and I'm going to start in the right lower quadrant, okay? So I want to start in the right lower quadrant because this is where the ileocecal valve is. If there's any paralysis or any obstruction, I would hear it here. And I'm going to do an upside down U and hit all 4 quadrants. I want to make sure that I'm listening to at least 5 to 30 vowel sounds. Okay, anything below 5 is hypoactive. Anything above 30 would be hyperactive vowel sounds. Also, I'm going to hear timpani above hollow organs like the stomach and dull over solid organs. So that's something to keep in mind as well as I'm auscultating. So I'm going to do that. If I don't hear any vowel sounds, I must wait at least 5 minutes in each quadrant, so that's a total of 20 minutes, before I document absent vowel sounds. This is an emergency. This could indicate obstruction, a paralytic ileus or bowel, and it should be reported immediately to the healthcare physician to be resolved immediately. This is an emergency. So I'm going to auscultate, okay, and I'm going to listen. Okay, in all 4 quadrants, I'm expecting to hear some vowel sounds, okay, and I would document that, what my findings. After I listen, I am going to now palpate. So I'm going to start with a light palpation, 1 to 3 centimeters deep. I'm checking again for any masses, anything hard, any hernias, or to see if I elicit any pain reaction from my patient. And then I could go on to a deeper palpation, 5 to 8 centimeters. Again, I'm checking for any masses, any hernias, anything unusual or abnormal, or to see if my patient reacts to anything. Okay, so this concludes the abdominal area. If you can just sit up for me, please. And just sit down straight. Okay, perfect. And what I'm going to do now is just assess the lower extremities. Okay, my patient has pants. Normally I would see the skin on the legs, but what I'm checking for is excessive dryness, any varicosities, edema, any signs that show venous or arterial problems. I would assess that here. Everything looks good. I will palpate for temperature. Should be warm. The skin should be intact and smooth. And I'm also going to check range of motion and strength. So I'm going to ask you to just please stand. And then what I want you to do is just show me. Okay, we're extending our legs. I want you to flex like this. Good. Okay. And I want you to plantar flex your toe. That's like pointing. Dorsiflex. Okay, like that. And then inverse in and everse. Okay, good. Very nice. Good range of motion. Okay, have a seat. And I'm just going to now ask a few questions about genitourinary topics. And how many times do you urinate in a day?
7.
About 7 times.
Yeah.
And what color is your urine?
Clear.
Clear. And does it smell? Does it have any specific odor?
No.
So odorless. Do you ever experience any pain, discomfort,
No.
like a burning?
No.
So everything perfect, no problem. Okay, and one last thing before our visit is over. I want you to just walk a few feet forward, just a normal walk, and then return. I'm looking for a rhythmic gait and balance, and You can go ahead, and I'm going to see, okay, it's rhythmic, then balance. He's not moving from side to side. Very nice. Okay, so good range of motion, good body strength, and everything is looking good. So I look forward to seeing you next year for your annual visit and your wellness. Keep doing what you're doing because you're in great health.
Thank you.
Okay, so you can exit the room here, and now I'm going to continue my assessment video. I'm going to conclude it by doing an educational piece. Living here in South Florida, I think that this is very important, is to protect our skin and skin cancer prevention. We have scorching hot heat, sun all year long, and especially if you're fair skin and have light eyes, you're the most susceptible to the damages of the sun. So like myself, I have light eyes, light skin, so I'm a victim of this. I'm, an easy target to get damages of, skin damages from the sun. So I have to protect myself like many other people. Okay, don't forget your eyes. Your eyes also need to be protected from the sun, so you want to use sunglasses, sunscreen. I would say minimum SPF of 30 if you're going to be out for many hours, for leisure or for work, an SPF of 50 or more. You could use long sleeves, hats, caps, umbrellas. There are many ways to avoid excessive sunlight. So one rule that I like to teach my patients is the ABCDE rule if they notice anything unusual about any moles on their skin. So A would be asymmetry, asymmetrical rugged borders, it's not round, it's not a perfect oval, so just strange border-like moles. B is for border irregularity, so it's similar. C would be color changes or multicolored moles. This is not a normal finding. This is something that might, you might want to seek a dermatologist, a specialist to take a look at. D, diameter. If anything is really big or has a size of 6 millimeters or more, that's something to worry about. I would probably get a referral from a PCP to see a dermatologist and have that looked at, taken care of immediately before it gets worse. If caught early, it's a good preventive measure from things getting worse or to that malignant stage. And E is elevation or evolution. Has it grown or evolved? Has it changed in any way? Is it elevated? These are just little cues that hey, you might want to have someone look at that. Okay, and I think educating our patients is probably one of the most important aspects, upon discharge. You want to make sure that they're going home with enough knowledge to be able to maintain good health for long term. You're not going home with them, so you want to make sure that they're getting that education, that they're willing to learn and willing to comply. So this concludes my assessment video, my head-to-toe examination. I hope that you've learned something. I know that I did, and I'm very happy to have shared this with you. Thank you very much.